Salivary gland cancer, major parotid gland, drains into the oral cavity via Stensen's duct near the second molar. Mucoepidermoid cancer is the most common parotid cancer. The submandibular gland drains into the oral cavity via Wharton's duct near the sublingual caruncle underneath the tongue, and the sublingual glands drain via the Bartholin's duct. Minor, most common lymph node spread are found throughout the oral cavity, paranasal sinuses, and pharynx. So again, these are minor salivary glands. 75% of salivary cancers are of the parotid gland, 75% of parotid masses are benign, and then 75% of minor salivary glands are malignant. Pathology includes pleomorphic adenoma, which is benign, Warthin's tumor or cystadenoma lymphomatosum, which is benign, acinic cell, mucoepidermoid adenocarcinoma, squamous cell is most likely metastasis from the skin. Adenoid cystic and carcinoma ex pleomorphic adenoma. Workup H&P, assess for painless mass history, mass effect, cranial nerve 7, other cranial nerve palsies at the base of skull. Trismus would indicate parapharyngeal involvement. Do a skin exam to rule out skin as the primary with metastatic disease to the parotid. Biopsy, do an FNA biopsy. Imaging, CT and MRI head and neck, CT chest, especially for adenoid cystic. Others do an audiology and dental exam. Differential diagnosis, rule out skin cancer with parotid nodes, rule out cysts, rule out sarcoidosis, rule out Sjogren's, rule out sialadenitis, rule out Bell's palsy and lymphoma. Staging. T1 stage is less than or equal to 2 centimeters. T2 is 2.1 to 4 centimeters. T3 is greater than 4 centimeters for extraparenchymal extension. T4A is FEMS, facial nerve, ear, mandible, skin. T4B is SPEC, SPEC, skull base, parotid, encased carotid. Low grade is acinic and low-grade mucoepidermoid. High-grade tumors include adenoid cystic, salivary ductal carcinoma, high-grade mucoepidermoid, carcinoma ex pleomorphic adenoma, squamous cell, anaplastic or undifferentiated, and malignant mixed carcinoma. General principles: recommend surgery for all, primary radiation only for unresectable or inoperable candidates. The role of chemotherapy is currently not known, being investigated in RTOG 1008. Would not recommend chemo on boards. Surgery should be parotidectomy. Total if there's deep lobe involvement, meaning deep to the facial nerve involved. Ipsilateral levels 2 through 5, neck dissection of high grade or clinically node positive. Post-op radiation indications, extraparenchymal or extraparotid extension, positive margins, intermediate or high grade histology, tumor spillage, T3 or T4 disease, meaning greater than 4 centimeters or extraparenchymal extension, FEMS. Positive nodes, perineural invasion, lymphovascular invasion, recurrence after initial surgery. In other words, radiation for all except the benign or small low-grade T1, T2, or very small intermediate high-grade. Radiation category 2B for T1, intermediate high-grade. Radiation is to the ipsilateral neck if high-grade, except adenoid cystic and acinic cell. You don't need to treat the neck for these. Or large, T3 to T4, or N-positive. Unresectable or cannot achieve full resection with gross residual disease. Definitive radiation. Neutrons have higher local regional control, so refer for neutron treatment. 17 to 22, N gray. Adenoid cystic do not need to cover neck, but do need to cover nerves. Evidence: try to spare the facial nerve with the surgery, otherwise nerve graft and plastic surgery. Avoid enucleation, 80% have a local recurrence. RTOG MRC trial of 25 unresectable patients randomized to neutrons versus photons. 10-year local control, 56% versus 17% in favor of neutrons. There is no difference in overall survival. Technique: IMRT is favored if treating neck, wedge pair, anterior and posterior obliques. Electrons, photon-electron mix. Techniques and planning: SIM, supine, neck hyperextended, mask, wire the scars, fuse the MRI. Volumes: intact disease, GTV plus 5 millimeters equals CTV 70. The remainder of the gland in high-risk dose level, and then neck if indicated. Alternatively, neutron 17 to 22 neutron gray for gross disease. Post-op per RTOG 1008, 60 gray and 30 fractions to the post-op bed and involved named nerves and involved neck. 54 gray to the remainder of the neck. Boost to 66 if you had a close less than 1 millimeter or positive margin, or if there was extranodal extension present. The CTV 66 is the tumor bed plus 5 millimeters or involved nodal bed with extranodal extension. CTV 60 is the tumor bed with 1 centimeter and involved named nerves plus 1 centimeter and involved nodal regions. CTV 54 by site, the parotid is the entire pre-op volume of the parotid gland and post-op surgical bed. If you had a superficial tumor, status post superficial parotidectomy, cover the remaining deep lobe. For a deep lobe tumor, status post total parotidectomy, cover the ipsilateral parapharyngeal space. Take the volume up to the skull base to the stylomastoid foramen if the facial nerve is not involved, up to the facial nerve canal and the petrous aspect of the temporal bone. If the nerve is grossly involved, cover ipsilateral levels 2 through 4. If there are positive nodes, then cover high level 2 and ipsilateral 1B and 5. Include the surgical scar in this dose volume. For submandibular sublingual cancers, cover the entire pre-op volume of the gland and the post-op bed, including the entire submandibular space. If involved, V3 via the lingual nerve or inferior alveolar nerve or the hypoglossal nerve, take to the skull base, the foramen ovale, or the hypoglossal canal near the base of skull, medial to the jugular foramen by C1 of the clivus. Cover the ipsilateral neck, levels 1B, 2 through 4. If they're positive nodes, then high neck and 5. Consider contralateral 1 and 2 nodes if ipsilateral level 1 is involved. Constraints per RTOG 1008. Cord 45 gray max, brainstem 48 gray max, lips mean less than 20, oral cavity mean less than 30 gray. Contralateral glands, parotid or submandibular, mean should be less than 39 gray. Esophagus mean is less than 35 gray. Larynx mean less than 35 gray. Cochlea max less than 50. Optic structures max less than 30 gray. Toxicity and follow-up 5-year overall survival for stage 1 is 80%, stage 2 is 60%, stage 3 is 50%, stage 4 is 30%. Local control for low-risk tumors or small, low-grade negative margins is 90%. For high risk, treated with surgery alone is less than 50%. Surgery and radiation is 90%. Inoperable photon treatment is 30%. Neutron is 70%. Damage to cranial nerve 7 often results in altered cosmesis with a facial droop, corneal abrasion, nasal congestion, and slurred speech. There is loss of salivary function permanent after 35 gray. In follow-up, need to image chest for adenoid cystic due to the risk of lung metastases.